All right, good morning. This is Senate Health and Welfare on this beautiful day, April 4th. And we are looking at some bills that have come to us from the House. Just to say that we have a lot of bills that have come to us from the House, and we'll try to go through them as much as possible, knowing that the House has done a significant amount of work. And I think we want to respect that and understand what it is and then move forward. So this morning we have H 233 regarding pharmacy benefit managers, and Representative Cordes is here. Thank you for being here. Why don't you give us the intro to the bill?
Happy to. Thank you for having me this morning.
You know everybody, right?
It wouldn't hurt to do.
Okay, let's do it.
There's still a lot of
Thinking that-
representatives I have.
Yeah, well, there's a lot of them over there,
We
right?
know each other. You two can go.
So, go ahead.
I'm Dave Weeks from Proctor, representing Rutland County. Nice.
Good to meet you.
Actually, I met you at the Fine Arts Dormitory. When I came
Yes,
through one
when
day.
you first
Early in the
first
season.
opened up that campus, yes.
I'm Terry Williams, I'm from Holton, and also representing Rutland.
We're surrounded by Rutland here.
And you're not related to the Representative Terry Williams.
No, we just did each other's email all the time.
And I represented Mari Cordes. I represent Lincoln, Bristol, Moncton, and Stars Code.
So 233, tell us a little bit about the bill and then we'll ask some questions.
Sure, I'm happy to. So the H 233 is a continuation of work that House Healthcare started in the last biennium. And it addresses the problems that a specific part of the drug supply chain called pharmacy benefit managers, or PBMs. It addresses some of the problems that their business practices have caused in the supply chain. And if you haven't read it yet, I highly recommend that. Is that the snow, or is someone,
The lights are
the
flickering.
lights are flickering? Yes, something to say about.
Sign of heavy snow.
We have a generator.
Oh, that's right. Jennifer Harvey did a wonderful side by side of the bill that became Act 131 in the last biennium and this bill. So both bills were focused on PBMs. Yep, and we're just continuing the work. So H 233 is a strike all, and it actually Jennifer Harvey Legislative Council created a whole new chapter in statute. So PBMs earned their way into their own chapter 77 in the health part of the statutes. So that's why when you go through the bill, a lot of it is underlined, but is already current law. And Jen did a great side by side. I encourage you to look at that. So you can see what part of H 233 is actually new, and which is current law, but is moved over to its new chapter. So I've been working with stakeholders for quite a few years in the mainly in community pharmacy, independent pharmacies, but also with Medicaid and with our unions who also use their own PBMs or PBAs, pharmacy benefit administrators, because the practices of PBMs that are problematic are anti-competitive. So they, since the 1960s or 70s, when PBMs were first created as third-party administrators to help insurers manage their drug plans, their drug formularies, they have slowly but surely consolidated power in the drug supply chain in that part of the market. So they had a lot of and still do have a lot of proprietary practices that are anti-competitive. And in fact, over the last few years, FTC, the Federal Trade Commission, has paid a lot of attention to these practices. And there are several bipartisan bills in Congress now looking at the very same things that we've been working on here in Vermont. And then on top of that, there was a letter from 39 attorneys general offices across the state. And we're a signer, our attorney general is a signer on that letter to urge Congress to do something about the problems of PBMs. So the problems, there are 3 major PBM corporations that are both vertically and horizontally integrated. So you would have a situation where the same company with different names is the insurer, it's the health insurer, is the PBM, is the drugstore,
Distributor.
the distributor, the
Retailer,
drugstore.
everything.
And now they're getting into, as we all know, clinics. So with that market consolidation, they have been able to, over the past 10, 15 years, do things like steer, and you may all, or your constituents may all have experienced things like this, where PBMs get to decide what's on the formulary for a health insurance plan. So a health insurance plan, the drug formulary is a list of allowable medications that health insurance plan will cover. But the PBM gets to decide what's on that list of medications. And what they've been doing is steering through anti-competitive practices and contracts, forcing patients to use a medication that maybe their provider didn't prescribe, but because what the provider prescribed wasn't on the formulary for that insurer, they have to switch to a different medication. And so many of the medications that they are steering patients to are more expensive. But PBMs negotiate drug prices with the manufacturers. And this all happens in the black box, and we don't know the numbers, we don't have access to that information.
I put the black box out on everybody's desk when they get S98, but it wasn't even a complete black box.
That's what I'm thinking right now.
Yeah, that's what you think about, yeah.
So that's just a kind of a flavor of it. It's really complex when you get into all of the different ways that pharmacy benefit managers, some of them, especially the big ones, have been able to pull business away from independent pharmacies, community pharmacies. We've lost half of the independent pharmacies in Vermont. I don't know how many of you have had pharmacies in your communities that have closed. Pharmacies get paid in many instances less than what it costs them to dispense a medication. The PBM pays them less. So pharmacies are having to pay for the privilege of dispensing a medication to a patient. So no other business could survive that way. So H233 goes a little bit further than we did with Act 131. Act 31 required that PBMs be what's the word, not licensed.
Register?
Thank you. Be registered. Licensure was a bigger step to take, so we had to wait till subsequent year to bring that one in. But there was very little, if no, there wasn't additional enforcement authority for the Department of Financial Regulation to manage some of these problematic behaviors and even get information about how much PBMs were paying insurers. Insurers had no access on a claim by claim basis to what the PBMs were paying a pharmacy at the counter. They had no idea. They had some aggregate information, but not on a claim by claim basis, so they couldn't see, they weren't aware of, other than the pharmacies telling them this was a problem. So now in Act, hopefully will become an Act, H233 requires PBMs be licensed. And excuse me. it sets up a licensing fees, and like council will go into those more. That will cover the work that DFR needs to do. DFR wrote a wonderful report, and if you haven't read it yet, please do.
It's very report.
Yeah, 131, please do read it, and you'll see a lot of what we've been talking about over the last few years in that report, and so DFR themselves said that if they were gonna do this bill passes, if we require licensure, it's such a complex system, they would need 3 FTEs to be able to do the work. So the licensing fees are established there by the Ways and Means Committee in the House, to be able to give the FTE, the resources for the FTEs for the Department of Financial Regulations to their work. It's appropriate for me to point something out, that one of my concerns about the licensing fees, and we went back and forth with DFR and legislative council about where to set that licensing fee. We know there are about 300 entities doing business as PBMs or PBAs. And if you want to know more about that, I'm sure Jen could go into that, in the state of Vermont. And yet some of them are PBAs, some of them are insurance companies that do PBM functions. So we had a hard time, it took us months to figure out, are we talking about licensing fees for 300, or are we talking about licensing fees for 34? Ultimately, DFR settled on the 34, 35, Jen can be more accurate. So the licensing fees were set on that number. I have a concern that I have been talking with Jen and Nolan about, wanting to make sure that smaller companies that provide PBM services are not unproportionately impacted by the licensing fees. So Nolan has been working on this, and he has
So
some
they have kind of a
suggestions.
gradation
Yeah.
based on size.
Yeah. I think I'd like to close with, as a nurse, I've worked with pharmacists, all of my career. And during this work, my respect for them and what they do for us and for our constituents has just grown. They truly are a critical part of our healthcare system. Many of us may remember having pharmacists that knew our whole families. And if you lived near a pharmacy, your grandmother could walk down the street and get her prescriptions from a healthcare professional who knew her well, who knew her history, knows the family history. And that's just, in most cases, not the case now. It's unfortunate. So it may be too late to save the remaining independent pharmacies, so I hope we can. But at the very least, I think we should be considering pharmacies and pharmacists as like foundational part of any healthcare reform as we go forward. And I'm really thankful for your work on S98, and look forward to working more with you.
Well, this is great. What was and before I give some final comments, but what was the vote in committee? You remember?
It was almost unanimous, I think it was unanimous. I can't remember. I can get you that.
Okay, and then there was a voice vote on the floor.
Unanimous.
Oh,
Yeah.
another one of those. And just to say, thank you for continuing this work. I know that we've worked in the past on transparency, on importation, on PBMs, and this is the big cost one of the big costs in our system, so I'm really pleased. So we'll go through the bill and we know where the expert is over in the house.
Thank you.
Get back to you.
Yeah, thank you for bringing that point up, that when people, we did have the representative from Pharma come in and speak with us, and it's interesting that because most of my focus and many of our focus is on the massive increases in drug pricing over the years, I always used to think of the pharmacy companies too, and I didn't know that the PBMs were actually a huge driver in the increase in medication costs.
They didn't start that way, but they've ended up that way. It's always a way to increase your profits.
Mhm.
Senator Williams has a question, and then Senator Bullock has a question,
Oh,
and Senator Weeks has, wait, all three of them. Everyone just,
I get to go first?
yeah,
All right,
yes, you do.
thank you for your testimony.
You're
It's-
welcome.
I mean, it's like, every day there's something new that I learn. I like to know the genesis of this bill. You know, obviously, I just found out you were a nurse. So what was your experience? Was there a constituent that came to you?
That's
And
such
ask
a
you
great
where to go?
question. It was a representative of the community or independent pharmacies. And when I live in Lincoln, and one of our beloved pharmacies in Middlebury, Marble Works, closed.
They did.
And that a big part of that was the PBM issue, and there were other problems that really hurt the community and community members that came out of that closure. It was a mess for a while.
To your point, I can remember in my town, we had McShane's Pharmacy. You know, and at least 3 generations of pharmacists. And I went down to pick up a prescription for my grandparents. And the pharmacist looked at that and said, why are they prescribing this? Oh, just here to pick it up. There was the 2 prescriptions would interact to get on another prescription that she was on. And he picked it right up, called the doctor, and got it fixed. But who would know?
Yeah,
So,
yeah, good
That
point.
is the value. It is a value, yeah. Senator Bullock.
Mine wasn't really a question, it was more just a comment. It's a snow day and we're all feeling kind of relaxed, but thank you for your testimony. I'm also learning a lot. I'm so naive about how a lot of this stuff works, but your comment about how pharmacies are an integral part of our healthcare landscape resonated with me, and I always think about times when I've lived overseas, and it was always interesting to me that you can go into a pharmacy in other countries and they will treat you. They actually have the,
Antibiotics.
yeah, they have the, what's the word? They've been given the authority or the scope to treat. Now, I'm sure it's not serious illnesses, but when I go in for, small things, they just are able to treat you. And I guess I always liked that because it takes out this step that sometimes can be, problematic.
I'm so glad you brought that up because that is a part of the vision that we as the stakeholders who worked on this bill had, especially in rural parts of our community where they might not have a full-fledged health clinic, but they might have a pharmacy. And pharmacists, we did expand scope of practice for pharmacists. And you may have noticed during the pandemic that they were able to prescribe and administer immunizations and medications around the pandemic. And that's another thing that PBMs were doing. They were trying to limit pharmacists' scope of practice and tell them what they could or couldn't do. And they have the only people that should be limiting scope of practice are the professional board for pharmacies, not PBMs. But to your point, a pharmacy could be a small little clinic in a rural town.
Question.
thank you, Marty. So again, this is a new topic.
You're in healthcare, it's deep, isn't it?
Sadly, yes.
We did glance by it when we were doing S98, but now we're gonna get into it more, and yeah, it's been an ongoing issue, and we've done steps along the way. This is another good step. appreciate you bringing the bill to us. Great.
So I'm curious though, how licensing affects the problem. Where's the linkage between licensing and registering and trying to solve the problem that you are?
Great question. So, the Department of Financial Regulation hasn't been they've been aware of, some, practices that, even since we passed Act 131, and pharmacies are aware of practices that PBMs are still doing that, I don't wanna characterize them, but need attention, more attention and need more information, more light shown on, the transactions that happen in that black box. So with the licensure, DFR will have more authority, expanded authority to regulate PBMs and get the information they need to do that. It will, not only do we have a new chapter in Vermont statute devoted to PBMs, we'll have a section of DFR devoted to digging into what are the mechanics of the problems that PBMs may or may not be causing in Vermont, and then how to address them. So
I'm gonna suggest that we're gonna have testimony from DFR and others that may help answer this question.
Yeah, but I'd like to hear it from this.
Yeah, we can do that. Let me finish my thought. So I'm gonna suggest that, Mari, you finish that, and then we'd have Jen come up briefly. I wanna get the 10,000 foot on the bill before we move on to the next one, so you can finish that briefly.
Thank you.
You're in charge, Senator.
happy to talk more too. And just last final note, Jen Kirby just said the vote was 11-0.
So what's a PBA? What's the difference?
Jen, so it's not as, they perform administrative, work, but they don't do all the other practices, some of which I got at with the creating a formulary, but I think Jen would be better, or DFR would be better to
Okay,
ask. So it's like a mini version of a PBM. They don't, and Vermont Medicaid uses a PBA, not a PBM. And in the work that we've done, we've really appreciated Vermont Medicaid as a model for how we might work with a PBM, or even in the original form of the bill, there was a wholesaling section that is no longer in there, but
so how do we get out ahead of this? Because it's like, fortunately, some of us remember the way it used to be. Now you're looking at the way it is and the problems that have been allowed to transpire. And it ends up costing DFR more man years, which costs the taxpayer more money, and how do we get out ahead of something like this so it doesn't get to the stage of being a problem?
a lot of it, because it's a national problem, a lot of it would be helped by congressional efforts, and like I said, they are working on that. In the meantime, in order to try to help Vermonters and Vermont actually save money, this work can save money and keep independent pharmacies, hopefully the rest of them, alive.
Can I just posit something as someone who doesn't know much about this, but it just seems like,
No, I didn't get to ask my questions.
You're
No,
in
I'm done.
charge.
I'm done. I'll wait for the
No,
test.
you
The other, no, you're very clear.
you did ask your question.
No, I did not ask my questions.
Huh,
okay, as we,
No, I got the
well,
message.
so,
No, I'm done.
can
I'll
I,
wait for the testimony.
can I speak? Right, because what I was gonna say in response to Senator Williams's comment was it just seems like this is an example of what happens when you've got a profit-based healthcare system. This is capitalism run amok, as far as I'm concerned. I'm just sorry, he asked a question and that's my observation. When you don't have regulation on something, it goes sideways, like PBMs. exactly
So-
what that is.
Senator, please, if you have a
No,
question.
I'll wait.
All right, right.
I'll do as you said.
Alright, so we're good. I didn't mean to stop the conversation, but we have exactly 2 minutes left to the bill, and I want to make sure we got to some level of look at the bill. We'll do that. Make sure you, right,
Yeah, well, let's talk more.
yeah,
Thank
there's
you
a
so
lot
much.
to learn here, and I really appreciate your time. Thank you. So Jen, let's just take a quick look at the bill from the high level.
Yes, and I.
And then
I'll say,
your question was, how does this solve the problem? That was your-
I really didn't get to ask my question. That's. Well,
Good morning, Jen Carvey from the Office of Legislative Counsel. We are looking at H 233. I also sent Olivia a couple of documents that she's posting. I updated the section by section summary to reflect the as passed by House version, and then thank you to Representative Cordes for reminding me about the side by side. So I updated the side by side comparison as well, so it to reflect.
Which one is the best to go through to get an understanding of what's in the bill?
Probably the section by section,
Okay,
but the side by side indicates what's changed from current law.
okay.
So I can put up the section. Do you want me to just walk you through the section by section then as opposed
Yeah.
to the bill?
Yeah.
That. So,
Maybe a little bigger.
this is the section by section summary as passed by the House. So as Representative Cordes said, it adds a new chapter on pharmacy benefit managers, PBMs. Not everything in it is new. That's why the side by side comparison with current law can be helpful. But it takes a few different statute pieces and combines them along with a new framework in a new chapter. So it sets forth first the purpose. It's to establish standards and criteria for licensure of and regulation of PBMs by protecting the public, promoting insurer solvency, consumer savings and fairness, providing a DFR with authority, and it sets penalties and fines for violations of PBM laws. So that's sort of a nutshell version of the why on licensure. The definitions are mostly the same as existing law, rulemaking, and it directs DFR to adopt rules, and it includes a requirement that PBMs file their advertising materials with DFR for approval before distributing them. Reporting, there's a requirement that DFR report to the legislative committees annually on how PBMs are complying with the chapter. There's the licensure requirement, and as it came out of the House, there is a $1,600 application fee. That's a one-time fee. $10,000 initial licensure fee and $12,000 annual renewal licensure fee. As Representative Cordes said, we're still looking at some options for licensing fees. They have been significantly lower coming out of House Healthcare based on initial estimates from DFR, but the whole idea here is to have the licensure fees support the 3 employees who will be doing the work of regulating the PBM. So that is why the numbers, once the projected numbers of PBMs to be licensed went down, the fees went up. We're still working with DFR to understand where there might be some additional options there. PBM prohibited practices. There are a lot of existing provisions in law that limit what PBMs can do. They relate to issues like banning limits on what pharmacies and pharmacists can say to patients. These are sometimes referred to as gag clauses, and setting limits on what patients have to pay out of pocket for their prescription drugs. There's 2 new pieces in here. One is copay accumulator language. Says everything that is paid by or on behalf of the patient for their prescription drugs out of pocket should count toward their deductible and out of pocket limits. There are some limitations on that about third party, like drug manufacturer coupons. If there's a generic version of the drug and the patient doesn't need to be on the brand name version, then they wouldn't get that manufacturer coupon counted toward their out of pocket, but that's the limitation when you look at the language. There's also a ban on spread pricing. So this is a common way that PBMs can make money is they charge the insurer or patient more for the drug than what the PBM pays to the pharmacy for that drug, and they keep the difference. That difference is called the spread. And so it can be a very small amount on a per drug basis, but it can, given the volume that some of them work in, it could be a lot of money. And so this would ban that spread pricing model. There's an enforcement and right of action. So not only would DFR enforce compliance with the chapter, and the Office of the Healthcare Advocate would have access to information, confidential information, in order to make sure that the consumers are being protected. It also provides for a private right of action. So somebody who feels they've been wronged by lack of compliance with the PBM statute could also go to court over that. Compliance, just saying we're not trying to violate federal law here, should be construed to be in compliance with federal law. 3615 allows DFR to charge or bill back to the PBMs for DFR's reasonable expenses in regulating them. This is fairly common in a lot of these insurance and other industries. The Green Mountain Care Board has bill back authority. DFR has bill back authority in other areas that it works in. So this is doing the same thing there. Insurer audit of PBM activities, the same as current law. It requires PBMs to let the insurers they're contracting with have access to certain information to make sure that the PBM is complying with their contract. PBM required practices with respect to health insurers. Again, most is the same as in current law, requires PBM to act in insurers' best interests. This fiduciary standard language that we added in the act that was passed 2 years ago, so that's new then, and it's maintained here. PBM required practices with respect to pharmacies. Again, most is the same as current law, requires prompt payment of claims, same reimbursement for non-affiliated PBM affiliated pharmacies as for PBM affiliated pharmacies, provides some protections for 340B covered entities and their patients. There's just a carve out on Medicaid from some of the 340B provisions because of the way Medicaid interacts with that federal program. Then we get into a couple of different statutes. So leaving that new PBM chapter, there's an amendment to ABSA 4084. There's an existing statute that prohibits health insurance marketing and advertising from being misleading or deceptive. This adds PBMs into that, which is currently a restriction on health insurers now that would add PBMs as well. Section 3 amends the statute on health insurance coverage of prescription drugs, but adds the same copay accumulator language in there. It also prohibits insurers and PBMs from trying to regulate prescription drugs or pharmacies or pharmacists in a way that is more restrictive than or inconsistent with state or federal law or the rules of the Board of Pharmacy. Prohibits PBMs and pharmacies from directly contacting a patient without the patient's consent in order to market the pharmacy services, except if there's certain circumstances where the patient is already engaged or had some other connection that would make that allowable under the statute. And it prohibits an insurer or PBM from changing a patient's prescription drug order or their choice of pharmacy without the patient's consent. It does also specify that this is not supposed to interfere with our generic drug substitution law, but it's just to say that the insurer or PBM can't be the one making that change. Then it talks about kind of the next few sections are how do we do this transition from the existing state of the law to this new licensure statute and other provisions when there are existing PBM contracts. So it keeps the existing PBM laws in effect until July 1st, 2029, but it says to the extent there's conflict, go with the new law. And then talks about the applicability, the PBM provisions relating to contracting and to benefit design would apply to a contract or health benefit plan issued on or after January 1st, 2025, but in no event later than July 1st, 2029. So again, trying to deal with this existing contracts issue and not impairing those existing contracts, but also requiring a PBM that uses spread pricing, which will be banned under the new bill, and its existing contracts and would have that in place because we wouldn't be changing their existing contracts. They must report on the spread at least annually through 2029. So as long as they're continuing to use spread pricing, they have to report on it. In their next contracts, they can't use it. And then it gives PBMs 12 months to comply with the licensure requirement, those that are already operating. Section 6 is the 3 new positions Representative Cordes mentioned at DFR to regulate the PBMs, 1 attorney and 2 investigators. And it appropriates $405,000 to DFR from its insurance regulatory and supervision fund, which is where that money will go into in FY25 for PBM regulation. And the bill would take effect on July 1st.
So is there a place in here that DFR can evaluate the contracts? The PBM contracts?
I think that may already
Is that,
be in
is
place.
that already in statute?
To the extent it's not, yes, there is language in here about, it's the same piece that allows the healthcare advocate. So it gives, there's confidentiality provisions, but yes, there are protections to protect the information, but yes, it allows DFR and the Office of Healthcare Advocate to review the contracts.
All right, questions for Jen? There's a lot here, obviously, and a lot of background information. We need.
Yes, and I think DFR has been, Sebastian and DFR has been very helpful to the House Healthcare Committee in explaining kind of where PBMs fit into the drug supply chain, so that might be helpful threshold information.
Any questions? Okay, so we'll come back to this, we'll go through and we'll look at what's new and what's old, and then we'll have DFR and other folks in to clarify, understand, what PBMs are, and then what regulation means, and then how that will help going forward. And Nolan would probably have a fiscal note on this one. There he is. So why don't you want to show that? Do we have it on our webpage or?
I didn't know I was expected to testify. I wasn't on the
No, you
agenda.
don't have to testify. We'll put you on next time.
I mean, I can do it now, or
This
you
is
have
the
Representative Hope
Yeah.
here, though, so I might. I'm happy to
Yeah.
come
Oh,
back. when-
We'll, if we have the fiscal note on our webpage, that'll get us started.
I can send it to the assistant, I don't know her name.
That's Olivia.
It's right, you have an issue brief on 72, but nothing here on that, so we'll hold off on that.
Thank you.
Thank you, everybody. Have a good morning.
I'm sure you'll be hearing from me.
Yes, there is a fiscal note, and I can do it after or whenever, but I think you might want to use Representative instead.
Yeah, let's do that.
Morning, everyone.
Good morning.
Beautiful, should have shared like at your window.
No. Okay, so welcome. I think you know everybody.
I do, yeah.
We're good. And this is H721. So why don't you introduce yourself and let us know what's in the bill, a little bit, how it came about.
Sure. So Lori Houghton, for the record, Chair of the House Healthcare Committee. So H721, there is a companion bill on your wall as well. A number of it. But Senator Lyons and Hardy are sponsors of that. And so I'm gonna just, if you don't mind, I'm gonna read the first section of my floor report, because I think it sums it up pretty well. So the cost of healthcare impacts Vermonters, all of us, leading to delayed care, stressing people's livelihoods, and increasing personal debt. H721 builds on a successful insurance program, and that's Medicaid. So our most vulnerable Vermonters, young adults, pregnant individuals, and other Vermonters, older Vermonters can receive the care they need, and sets in motion an expansion of Medicaid insurance to more hardworking, moderate income Vermonters. So why did we bring this forward this year? More than half of uninsured Vermonters identify cost as the only reason they don't have insurance. 88% of insured Vermonters have visited a doctor in 2021 compared to only 48% uninsured Vermonters. So, you know, obviously that's a big gap. There's a lot of people with not getting the healthcare they need. In 2021, 40% of Vermonters under the age of 65 are considered underinsured. And that means they have insurance, but they can't afford to use it. That number was only 30% in 2014. So it's been increasing every time we do the household survey. You see those numbers. And the highest rates of underinsurance are among individuals with the lowest incomes who are just over current eligibility of Medicaid. So during the federal public health emergency, as you all know, Medicaid was, but the federal government required us to keep people on Medicaid, without doing the annual redeterminations. People who lost their jobs could get on Medicaid and stay on, and approximately 30,000 Vermonters joined Medicaid during that time. The uninsured rate for Vermonters with incomes just above the current Medicaid levels of eligibility fell 6% in 2018 to 2% in 2021. So we saw that keeping people on Medicaid really worked. So what does H721 do? It raises Dr. Dinosaur right now, goes up to age 19. It raises it to 19 and 20-year-olds starting in 2026. It also raises Dr. Dinosaur for pregnant individuals. Currently, the eligibility is 208%, goes up to 312% starting in 2026. There's a big piece of it, working with older Vermonters, that I'm going to get to in a second. And then the other big section, section 4, is a technical analysis that we're requiring agency DVHA to do, and it's going to look at several things. So expanding Medicaid eligibility for everyone, bringing Dr. Dinosaur up to 26. So today, commercial insurance is required if you're on your parents' insurance to keep you there to 26. You think Medicaid should be able to do the same thing, because when those kids drop off at 19, they had insurance up to income of 312%. When they turn 19, the eligibility drops down to 133%, and so a lot of those kids are falling off and not getting insurance. And then it analyzes reimbursement rates, because we know providers will need to be paid more to cover this expansion. And it looks at our insurance markets to see what the impact would be. And it offers solutions should the ARPA subsidies go away in 2026, like they're expected to do at this point. And then it also examines the feasibility of a public option for small businesses. So it's pretty expansive technical analysis that will require at DVHA. I'm going to go back to how we're helping older Vermonters. So people often think when you turn 65, you get on Medicare, like it's great. But if you've been on Medicaid and you turn 65 and your income, you have low income, you end up paying a lot more. So you immediately have a $2,096 premium to pay for the year, and you have out-of-pocket costs of up to 20%, and you have no limit as to, commercial insurance. Sometimes, like I think we have a limit of, say, I make this up, $10,000 that we pay out of pocket for our healthcare. They don't have any out-of-pocket limits. So they could be spending a large chunk of their Social Security income on healthcare that they didn't have to do before. So I'm just going to give you some examples. An individual earning up to 100% of FPL, federal poverty level, which is $15,060 annually, so it's most likely coming out of their Social Security, is covered for both premiums and cost share when they get on Medicare Savings Program, which is a wraparound program we're talking about here, which is great. But if an individual earns 101% of the federal poverty level, which is just $150 more, they now have a year, $150 a year. MSP only covers the premium, so that's at $2,000, but they still have to pay the 20% of cost share when they go to a doctor. If an individual earns 136% of federal poverty level, which is $20,482 annually, they lose all assistance. And so they are now potentially spending, 20% just on the income, the premiums and the cost share, let alone if they have real issues and they end up having, to pay for surgery or something, they're paying a lot. So what 721 does is it takes the MSP, so the Medicare Savings Program, which is a wraparound program to Medicaid when someone turns 65 with low income. And it raises that to 190% of the federal poverty level. So that would be an annual individual income of about just under $29,000. And it raises the help with just premiums to 225%, which is about an annual income of just over 33,000. The really great thing about this program is there are federal dollars sitting out there today. So the federal government has a pool of money for this program that's not getting used. And in fact, there was a bulletin issued to all the states, I think in 2021, that basically said, there's a pool of money, why aren't you using it? And so we're not using it because it does require us to invest state dollars. So this expansion would be $15 million in general fund. It would draw down, I forget the number, I apologize, I think it's 30 to 40 million in federal dollars, and it would mean 19,217 additional older low-income Vermonters would be able to have some more help to get their health care. No one that came before us, and we heard a lot of testimony, did not like this program. It was a slam dunk for everyone, including the hospitals who have a lot of uncompensated care and bad debt, and they felt that this would really help lower that for them. And you know, at the end of the day, it's putting real money back into the pockets of older Vermonters. So those are the big things. There's a couple minor other little things that I can walk through, but that's.
So a question for you, understand that there are some, there's a financial section of the bill.
Yes.
That has some taxes in it for financing what is here, so.
Yes.
And that, whatever is there will go down the hall to finance, but maybe just mention what the taxes are.
Sure. So it's corporate taxes, and I'm not a corporate tax person, but it is corporate taxes that are mostly for larger corporations, only C corps, that sell into our state. And I'm gonna, yeah, thank you, that's what I needed. So there's two, thank you, there's two programs. There's something called GILTI, which is income earned from intangible assets such as copyrights, licenses, and patents. And there's something called FDII, which is another type of large corporate tax. And what happens today is the federal government is allowing large corporations to deduct this. And so they're not paying these taxes. And we're saying if we have them pay it, which we're allowed to, the federal government allows the state to do that, that would be part of the corporate tax that we're increasing. The other thing we are doing is raising the corporate income top marginal tax rate from 8.5% to 10% for the marginal value over profit of $25,000. So if a corporation makes is a profit of 25,000, the income tax rate goes up. And again, it's only C corps, and we actually own a small business, which for some reason is a C corp. I don't know why they did it years ago. For most small businesses, this will not impact them because they don't have this $25,000 profit. So those are the three areas. I think I got that right. Oh, and securities registration fees. Slight increase from 600 to 740 for large security companies. That fee has not changed since 2008.
Okay, so, and were that taxation was added by Ways and Means?
It was added by Ways and Means, yes.
And,
So-
yeah,
There's some appropriations in the bill itself for the technical analysis. But then they added, obviously, how we're gonna pay for it.
what was the vote in your committee?
The vote in our committee was 911.
Okay, and on the
And on the floor, gosh, you would think I would remember that because it was a very strong vote.
okay,
It was like,
was it a voice vote?
it was a voice vote. I think it was like 92 to something, and
Oh,
and we had, it was a roll call, and we had a dozen to a dozen and a half members across the board out.
Thank you. Questions for Lori? Representative Houghton.
Yeah, that's,
So anybody that was not in favor of this?
so, the bill itself, everyone was in favor of the MSP, the Medicare Savings Program for older Vermonters. The expansion in 2026, we heard a little bit from the providers that they were concerned that when originally the bill was to expand Medicaid to everyone. And there was a concern that if we did that without increasing reimbursement rates, there would be real difficulty for providers. But the numbers for increasing youth and increasing pregnant women are quite small. And so we didn't hear anything back from providers after we did that.
So is there any, property tax increases gonna have to happen to have federal, state money to match federal money?
So that is,
So-
so the $15 million that's needed for the MSP program, and then there's, I think the total is 22 million total for everything. That is where the corporate tax increases come in to pay for that.
That's a one-time
No, it's ongoing.
every year.
Okay. Other question, go ahead.
Yeah, just a curiosity question. So the raising the Medicaid limit for children to 26, based on their parents' financial circumstances. What if the 25, 26-year-old is able to purchase his own, he's got his own earning power? He's not eligible for Medicaid. What was the rationale for that lift, the age to 26?
Well, so if he would be above 312% of federal poverty level, then he would not be eligible
So
for
it's between the,
Medicaid, right? So, and I wanna be clear, this part of it is a study, we're only raising the 19 to 20-year-olds right now. There's a small portion of folks that this could hurt now, but for the most part, the data that we got from DEVA. This would help about, for 19 and 20-year-olds, this would help about 1,800 youth stay on Medicaid. Today, the group, only 400 of them buy off the exchange. So there's a chunk of kids who don't have health insurance when they reach that age, but the 26, that has to be analyzed.
second question. You said that you're targeting corporations with a corporate tax from 8.5% to 10% for all corporations that sell into the state, not.
No, so the marginal income tax rate is for all C corps. And it is the $25,000 and over, so if the profit is 26,000, then it would be an additional. It goes from 8.5% to 10%.
But are these corporations which are present,
Yeah,
operating in the state?
these
selling
are-
into- It says something about selling into the state.
I'm gonna actually ask Nolan to answer that.
If I could, for the record, Nolan, I won't join fiscal office, I would recommend that we do a separate session where we do fiscal note, and I'll bring in this, because I wrote the spending piece. And I have other folks do the revenue piece, so I would recommend we
I
bring
would
us
have
all
our
in.
tax attorney, I would have Kirby come in and.
Yeah.
explain
Yeah.
Yeah, we'll do that,
And
and
then
we'll,
we can answer all the questions, I don't think.
right, we'll do that kind of as much as we can, so we have that understanding of what we're doing,
Yeah,
what's recommended in the bill, and then finance committee is gonna have to do the deeper dive on this ultimately, but we'll do that.
Yeah.
And just so you know, when we heard from Ways and Means on this, the vote in our committee was 10-1 to accept the
Oh.
amendment. But I apologize, I
Don't apologize.
don't know this as
No,
well,
I know.
I know the bill.
Talking about the guilty tax.
Right,
No,
yeah.
No, don't even, it's bad enough, right?
Right,
So the bill, thank you for that. And then did you look at, we did work together
Yeah.
on the working group here a couple of years ago that with a consultant and Representative Houghton and I worked together to pull together some recommendations that were potentially helpful
yes,
to access and affordability. And some of what's here
yes, it's from that.
from that initial report.
Right.
There's other things in there.
And then I'll just touch on two things real quick that I think are really important. So one is we're recommending that DEVA present to our committees once a year to make the process for Medicaid and what it covers more transparent. So through the years, they're analyzing what services should be offered through Medicaid, what should be taken away, and we have no insight into that. And so we're asking that become transparent. And then the second thing we're doing is, as you know, with our global commitment, we have investment dollars that come in. And we ask every year for a long list of what are we doing. There's about 80 investments that we're making, and we don't really know what those are. And so DEVA has actually hired a consultant to start looking at that and make sure our money is being used appropriately and effectively, and not appropriately, effectively is the right word. And so they're gonna report to our committees yearly on that as well.
Maybe they'll report to ours as well.
Yes, absolutely.
Okay, great. So, let me ask Olivia, is Dr. Levine already on Zoom? Okay. Oh, hello. Okay, Dr. Levine, we're just gonna be a few more minutes. Do you have the time to stay on Zoom while we finish up on this bill?
Not a problem.
Thank you. That's great. So we'll go
Switching
through,
over, yes, I'm back with you at 11,
that's a good time.
and I don't know if we need as much time as you have
We have,
budgeted for what's on there, so we can pick up with this bill if you want.
good, we'll do that. That's perfect. We'll have time. It's Thursday, we have an hour. Good, thank you. So we're good,
Okay.
except 21. I
Right.
appreciate it, and I know I have the list of witnesses that you
Yeah, we
looked
heard
at, and we'll
from a
sort out
lot
what
of
we need to
people.
know and what
Yeah.
questions are.
Really positive feedback on this, so appreciate you taking it up. Thank you.
And your appropriations committee was,
Yes, they were supportive as well.
Oh.
I don't know the vote. I can send you all the votes. How about I do
we
that?
might have a different perspective over here. We'll have to see.
Yeah.
Yeah. Okay.
Have a great day. Thank you.
Thanks. All right, so, we have 1872. I'm gonna suggest, Dr. Levine, I'm gonna suggest a 5-minute break for the committee, so we can move from one set of topics to the next. So we'll come back at 10:05, and we'll have your testimony first up.
Not a problem. See you
No,
then.